Okay, it's 9 a.m. here in Jordan. Good morning, everybody. We're really glad that you're joining us today as well on our second day of the Jordan Nutrition Innovation Lab National Scientific Symposium titled Diet, Nutrition, and Health in Jordan, promoting science-based actions to support mothers, infants, and children. This symposium, of course, funded by the USAID, and it is organized by the Jordan Nutrition Innovation Lab at the Friedman School of Nutrition Science and Policy at Tufts University. Can we please give Tufts University, the representatives that they are here, as well as JNIL, a big round of applause. Yalla, أعلى. Shukran. This symposium as well is in a collaboration with the Ministry of Health, and again, another round of applause for the representatives of the Ministry of Health, as well as the University of Jordan. Okay, thank you very much. Actually, today we have, honestly, very important, enlightened as well, enlightening sessions. We will have a full day, but the good news as well is that His Excellency, the Minister of Health, will be joining us towards the end. Knowing Professor Firas Al-Hawari, he has always been very, very keen, especially on the research part, the evidence-based research part. So inshallah he will be joining us to give another probably informal speech at the end. Sorry? At 4? Yeah. Ah, okay. Yes, definitely. So for now, we want others to stay with us the full day. So I hope that the sessions as well are a big motive for your good selves, and we'd love having you till the end of the day. We believe that we will be ending second two at 5 o'clock. Just a quick housekeeping tips. Again, please remember to use hand sanitizers as frequent. You know that there's a COVID spike these days, and we want you to be safe all the time. As well as on your behalf, please allow me to welcome all participants, all those who are joining us virtually via Zoom, I believe. We'd like to tell you as well, to tell them that we have translation, both Arabic and English. So if you need your headsets, you could always get it from there. Thank you very much, and let's start directly with our first session. It's actually oral session number 2. Yesterday we had 1, and number 2 is titled Breastfeeding and Complementary Feeding Practices. This session will bring together invited speakers from UNICEF and competitively selected oral presenters from the CHN project, Tufts University, Al-Bayt University, the University of Jordan, and Al-Balqa Applied University. Our esteemed panelists and speakers will share cutting-edge evidence, whether published or ongoing, on practices and behaviors about infant and young child feeding, including findings on socio-ecological determinants of breastfeeding and complementary behaviors and practices in young child feeding with a key implication of highlighting gaps, actually challenges, barriers, opportunities, and areas for improvement for policies and programs in Jordan. Our dear moderator, Dr. Hana Al-Khateeb, will be moderating this session with actually probably 7 speakers. Let's welcome here, please, Dr. Hana Al-Khateeb from Jordan University of Science and Technology. Just تفضلي. انت كمان هنا.
Bismillah ar-Rahman ar-Rahim. A very good morning to everyone. We are going to start a very busy session. So what is going to happen, that we are going to have the first speakers of 3 speakers with us here at the stage. Dr. Wigdan Madani, Lana Khoury, and Dr. Shibani Ghosh. And once we are done, we are going to take our 4 gorgeous speakers afterwards. And after all the talks are done, we are going to accept the questions from our audience. So with our first distinguished speaker, Dr. Wigdan Madani, she's a nutrition specialist in UNICEF Middle East and North Africa Regional Office. She joined the UNICEF in 2007 and served with UNICEF Sudan, UNICEF Ethiopia, UNICEF Yemen, UNICEF Syria, and UNICEF Philippines. She's a nutrition and public health professional with over 24 years of experience in nutrition, public health, coordination, research, and surveys with academia and UN agencies. She supports the implementation of large-scale nutrition, curative, and preventive programs in a humanitarian and development context with extensive experience in systems strengthening. And before joining the UN, Dr. Madani was a research associate in the Department of Food Science and Human Nutrition at McGill University, Canada. And she got her PhD also from the same department, in Food Science and Human Nutrition, McGill, Canada. So please welcome with me Dr. Wigdan Madani.
Okay. Thank you, Dr. Hana, for the introduction, and good morning, everyone. I will start this presentation to talk about a landscape analysis that was conducted by UNICEF in 2019 for countries in the region, in the Middle East and North Africa region. I will start the presentation with a brief introduction. We'll talk about the goal and objective of the landscape analysis, methodology that was used, key findings, and also some key recommendations from the landscape analysis. Just to mention why this landscape analysis was conducted. There was considerable gaps that have been seen in achieving the global targets and also the regional targets for the SDG and the World Health Assembly targets in the regions, specifically with regard to the malnutrition indicators, mainly, mainly stunting, wasting, and overweight. Stunting is still very high in the regions with around 14.7%, stand at 14.7%. Wasting is at 7%, and there is increasing trends on overweight and obesity also in the regions, and the current regional averages stand at 11%. The underlying determinants of malnutrition are mainly diseases and also the diets, access to diets. So the minimum dietary diversity still stands at 38% as an average in the regions, and the minimum acceptable diets, as only 20% of the children are accessing the minimum acceptable diet that they need for healthy development and growth. So the overall objective of the landscape analysis is to conduct a kind of situation analysis on the complementary feeding in the Middle East and North Africa, to provide the basis for the development of a regional framework for planning, implementation, and monitoring of complementary feeding interventions. The landscape analysis focus on only specific countries, not the whole region. So Egypt, Jordan, Lebanon, Oman, State of Palestine, and Sudan were selected as the countries that landscape analysis focused on. So the aim is really to review the situation and identify key related gaps in the practices, including the determinant of complementary food, and also to identify the enablers and the hindrance of appropriate feeding. The methodology used, a combination of methods, literature review, qualitative interviews, brief quantitative survey questionnaire, and field observation in the 3 countries. So there were some limitation, the inability to conduct some field trips, specifically in Egypt, and also the security situation in Sudan and the State of Palestine, as well as the low response rate to the questionnaire. And given the scope of the study, it's only a binary logistic regression was conducted to identify the associations. So just quickly to go through the situation in the region. So wasting is increasing in some countries in the regions, and also stunting. Overweight also in a great increase. If we look at the low birth weight, Sudan is the highest in the low birth weight, followed, and also Oman is the lowest. Stunting is very high, with 38% also in Sudan, and in Egypt, and also in Oman. Wasting, also prevalence level are critical, and significant health problem in some of the countries like Sudan, Oman, and Egypt. And also there is increasing trend on overweight, reaching 14% as the case in the Egypt. And also trend analysis shows that the trend of overweight is also increasing, specifically in countries like Jordan, Lebanon, and also Oman. In addition to undernutrition and overnutrition, iron deficiency anemia is also prominent health issue in most of the countries in the regions. The level is high in Jordan, around 32%, 27% in Egypt, and 23% in Oman. Trend analysis was only possible for Jordan, which shows a decrease, but after it became stagnant. Complementary feeding practices among children 6 to 23 months. Also, the difference in the different countries of the region, with, for example, minimum diversity is highest in Oman, while lowest in Sudan. There is a great variations in the regions in the minimum dietary meal frequency and also the minimum acceptable diets. And the study also indicated a clear correlation between the dietary diversity and the minimum acceptable diets. It's important to have a diverse diet, to have a quality diet for the children. Key informant interviews also indicated food lack diversity, low nutritional value, and also the emphasis of the families on using starchy food for the complementary feeding of the children. So the analysis was done also to look into the association of the key determinants at the household level, determinant at the policy level, a determinant at the service provisional level, and the determinant at the household level on the feeding practices. Data was consolidated from a key informant interview and complemented by data from the study and peer review articles, in addition to a preliminary analysis of some of the house survey data for the associations. I will just take you through some of the key determinants that were identified at the individual level. Maternal knowledge and attitudes has been identified or perceived as a key determinant that affecting the complementary feeding habits. Followed by the nutritional status of the mothers, and also the success or the problem within the breastfeeding in the first 6 months. There was also analysis of the household data, show a significant associations between maternal education and the breastfeeding indicators, specifically the minimum dietary diversity and the minimum acceptable diet in Egypt and Sudan. Maternal educational literacy was also being associated with negatively associated with the feeding habit and practices of the complementary feeding. The second determinant that was examined is that the household level, grandmother and also fathers and also helpers and nannies are really found the key influencer on the nutritional or feeding habits for the mother, and also on the maternal decision on what food to give to the child. Other factors has been identified are the family food security and socioeconomic status, and this has been also confirmed by the analysis of the household data, which households with wells with high wells are really having a good complementary feeding practices. This is mainly in Sudan and state of Palestine, but it's less significant in other countries in the region like Egypt, Jordan, Lebanon, and others. Parental education has been to be significantly found to be positively associated also with the feeding practices, especially the minimum dietary diversity and the minimum meal frequency in some countries in the region. They also examined some of the determinants at the program level, and key informant interview have acknowledged that gaps in knowledge of the health provider, poor counseling and communication skill is really affecting the quality of educating mother on the breastfeeding practices. There is also lack of human resources, sustainable of the community-based interventions, and access to services. There was also a significant correlation between access to some of the services, especially antenatal care visits in Egypt and Sudan, on the feeding practices. At the policy level, there was also certain variation among the countries on having specific policies for IYCF. For example, in Jordan, Lebanon, there is a standalone policy, while in Sudan and the state of Palestine, the policy is integrated in the national nutrition policy. Also the code, the maternity protection, there is a wide policies, there is a wide variation among these countries in where the level of the implementation and enforcement of these policies in the region. Only Jordan has fully achieved the WHO recommendation for restricting marketing of food and non-alcoholic beverage for children. It's the only country in the region that has been seen to have this policy in place. The key recommendation came from this study, especially at the central policy level, is really to strengthen the coordination and collaboration between actors, leadership and prioritizations of nutrition complementary feeding, as well as to ensure the development and implementation and enforcement of the policies and legislation, and at the same time also what is critically strengthen the health system to deliver quality services. So at the service provision level, the key recommendation was to conduct assessment that consider cultural and geographical disparities, because within the countries there is a lot of disparities among the population, and also to implement a comprehensive behavior change strategy and intervention that will really help to increase the mother attitude and practices. Increase access to quality counseling and education services, and also increase the access to fruit and vegetables and meat, especially during the first 2 years of life of the child. As has been indicated at the beginning, the objective was really to come up with a regional framework and also country-specific framework. And we are working also with Jordan to develop this framework to improve the complementary feeding among children 6 to 23 months, not only focusing on the health system, but also focusing on the food system, addressing water sanitation issues and social protection services to ensure that food will be, nutritious food will be safe, affordable, and also available to all caretakers and mothers to provide it for the children. Thank you.
So thank you so much, Dr. Madani, for an eye-opening talk about the key factors that affect the child and mother health in the region, including Jordan. So we are going to welcome our next presenter, Lana Khoury, which is a senior research from the USAID Community Health and Nutrition Project.
Thank you.
And this is the clicker? Yeah? Okay, perfect. Okay.
Good morning, everyone. Thank you for this presentation. I'm very excited to be here with you this morning to share findings from a formative research that was conducted by the Community Health and Nutrition activity, and that very much echoes the specificity of Jordan and is very much in line with findings that Dr. Madani just shared with you. So yeah, this is quite a little bit qualitative in nature, and it kind of clarifies a deeper insights into the picture. In my presentation today, I will be going over, the objectives of the formative research conducted. I will touch base on the methodology utilized. I will be sharing with you some of the key findings that came out, and again, the limitation of the time would not enable sharing more, but we have the reports and they can be available for whomever is interested. And I will conclude with some recommendations for the way forward. So the formative research mainly tackled the key MIYCN behaviors that the Community Health and Nutrition Project focuses on. We aimed at exploring the key barriers and facilitators and the emotional drivers behind these behaviors. We also aimed at exploring who are the influencing audiences that we need to focus on and what are trusted sources of communication we need to utilize to reach them. We also aimed at exploring the social norms that are prevalent, which many times act as barriers or facilitators for adoption of behaviors, provider factors that can also be targeted in order to improve MIYCN behaviors, and we explored small doable actions that can also be included in attaining the change over time. For the formative research, we conducted 3 complementary studies. The first is an insight gathering activity, complemented by a social norms exploration, as well as a trials of improved practices study. Qualitative in nature, all 3, we utilize focus group discussions and in-depth interviews, as well as semi-structured interviews to address and explore the key areas. Due to COVID-19 restrictions, we were not able to conduct face-to-face data collection, but rather very much relied on the innovative use of technology, so we did all data collection virtually. Some key findings regarding maternal nutrition, and these are cross-cutting findings across the 3 studies. The family and the experienced mothers are very much the source of information when it comes to maternal nutrition during pregnancy. Despite the high utilization of antenatal care services, but still women would not consult healthcare providers on their diets. Through the TIP study, Trials of Improved Practices study, where we interviewed a group of 113 women, 4 semi-structured interviews over a period of 4 weeks, we identified a low consumption of the recommended 3 meals a day and low consumption of iron-rich foods, which was an area explored in the options that we gave to women to experience and to include in their diets. And the internet and social media were main sources of information when it came to maternal nutrition during pregnancy. Breastfeeding in general, there's widespread knowledge, there is lots of positive attitudes about the benefits of breastfeeding for the mother and for the child, despite the fact that this wide knowledge and positive attitude is not very much translated into practice. The support and advice is very much a family issue. It's a private family matter. Especially women express that they usually face challenges early on after delivery, and they will not consult healthcare providers for advice and support. Ceasing breastfeeding, women cease breastfeeding for a number of reasons. The insufficient milk supply syndrome that Dr. Hana explained yesterday, the baby unable to breastfeed correctly, and the issue of a child agency, where the child is perceived as the agent deciding on the success of the breastfeeding practice, and the woman's desire to become pregnant or herself becoming pregnant. There is wide use of formula milk to complement breast milk, and this wide use is very much fueled by social beliefs, by the lack of an enabling environment that does not permit breastfeeding in public. Some barriers regarding specific breastfeeding practices. For early initiation of breastfeeding, there is a common tradition and a common norm which reinforces the introduction of pre-lacteal feeds prior to the woman breastfeeding her child. The type of delivery is another structural factor, where C-section is very much hampering early introduction of breast milk, as well as the health facility policies and the provider norms. And this was very much expressed as an issue in private hospitals, where women will not be able to initiate breastfeeding early, and the child will be given formula milk even without consulting the mother. Exclusive breastfeeding is challenging and rare, and there is a common tradition and practice of introducing solid foods prior to 6 months of age. Women's employment, despite the low participation of women in the labor force in Jordan, this came out as a main factor that would not enable exclusive breastfeeding and breastfeeding in general. Breastfeeding up to 2 years, again, very much perceived favorably with support of verses from the Quran, but is impossible to put in practice. Complementary feeding, again, healthcare providers are not the trusted source that women would seek the advice from. The majority of children interviewed in the Tufts study were fed 3 meals a day plus 2 snacks, whether they were being breastfed or not. We identified a low consumption of animal source proteins, and this was an area that we explored with providing the mother with options to experience and to include in the child's diet. Feeding children unhealthy food is a common practice. It is socially acceptable. Everyone does it. It's an expression of affection for the child, unfortunately. Family nutrition, we mothers are the ones responsible exclusively about all aspects of family nutrition, starting with shopping, cooking, catering for the needs of the family. We identified a high consumption of sugar-sweetened drinks in the Tufts study, and this was again an area that we explored. Key barriers to healthy family diets, which was seen as something aspirational for the families, was mainly the financial constraints, and I think things are even deteriorating nowadays. The data collection for this study was conducted in 2021. There is limited awareness about the options, and there is limited access to the healthy options that women can include in a healthy diet for herself as well as for the family. Health service needs was an area that was explored with limitation. The care seeking from the public sector was common. The private sector was supplementing services provided in the public sector. Clients' perspective, from the perspective of clients, there is low satisfaction with public sector services, and this is related to a number of challenges that were expressed by the women. Long wait times, rushed appointments, there is a shortage of staff, there is a shortage of services, and there is a perceived low quality of services provided in the public sector. Demand was strongly expressed for women. They trust healthcare providers and they want to demand more health services and counseling, especially counseling on MIYCN issues across the continuum of care. From the healthcare providers' perspective, there is limited training that they received on MIYCN, and there are challenges that also hinder provision of quality in-depth counseling, which are related to systematic issues related to the workload, the patient volume, as well as insufficient time. COVID-19, definitely, who wasn't impacted by COVID-19? It impacted the availability of services as well as access of women to services in general, with a focus on MIYCN. The way forward, future efforts, I think, would benefit from building on the following. There is a very strong desire among women, whom we included in the study, to take action and to increase demand for quality MIYCN services, so we have to invest in this. There is a need to address the behavioral determinants at the individual, at the social, as well as structural levels, with use of complementary multi-channel approaches, which are participatory in nature. And we have to use media innovatively as well to reach women. Interventions we design have to be client-centered, whether we're addressing supply side or the demand side. There is a need for more support services at the level of community, and there is a need for more client-centered counseling and services at the level of healthcare facilities. Small doable actions is they're a window of opportunity where we can invest in promoting small doable actions that will have incremental change over time to attain the targets that we aim at or the outcomes that we aim at. And the issue of access versus diverse diet. Again, affordability is an issue, but knowledge about the options that are available and making the right healthy choices, the easy choices for women, and the quite interesting choices for women to include in their diets is a key area that's worth further investment and further interventions in. Thank you very much. I'm done. Yeah.
So thank you, Lana, for putting more focus on the nutrition, environmental, and behavioral factors that affect the mother and the child. And we all know that it's going to have an impact later in their life. Now it is with pleasure to welcome our next speaker, Dr. Shibani Ghosh. She's a research associate from Tufts University, and she's the principal investigator of the Jordan Nutrition and Innovative Lab. So yeah, welcome.
Thank you, Dr. Hana, and I promise this is the last time y'all will hear me speak. I've kind of taken over the stage here. So I kind of feel like I'm following two really phenomenal presentations, and that really set the stage for the analysis I'm going to present today. We utilized the Jordanian Population Family Health Survey data that's collected every 4 to 5 years, and did a quantitative analysis of complementary feeding practices. And I think you will find that the findings across the MENA region using qualitative work that Lana and colleagues at CHN have done, and this quantitative analysis points to the same direction. I'm going to not go through this because I think we've set the stage of why it's so important. Why is complementary feeding so important? Why is exclusive breastfeeding so important? I just do want to highlight one point is that we often miss out on the fact that we need appropriate and timely introduction of complementary foods. That is, it shouldn't happen too early, but it shouldn't happen too late either. So we have to balance those sort of messages around exclusive breastfeeding and timely introduction of complementary foods. So that's really what I want to like to say here. As I mentioned, this was a study that was looking at quantitative data over time. So essentially the objectives were to assess trends and changes in breastfeeding and complementary feeding practices in Jordan, and examine the factors associated with them. Now for the specific presentation, I'm primarily looking at complementary feeding practices. Our report outlines extensively around breastfeeding in children under 6 months of age, and this is available, it's been finalized and it's available. So in this presentation, we'll really look at the consumption of breast milk substitutes, ultra-processed foods, relative to complementary feeding indicators such as minimum diet diversity and minimum acceptable diet. So this is just to give you the definitions of the outcome variables that we are looking at. So minimum diet diversity in the case of our analysis is basically if a child has consumed 5 or more of 8 food groups. Minimum meal frequency is defined as the number of times a child receives meals, snacks, or milk feeds in the previous 24 hours. And these have been outlined by the WHO in terms of the number of meals if you are a breastfed child or if you have a non-breastfed child. The meal frequency and the minimum number of meals changes. And finally, a minimal acceptable diet is the proportion of breastfed children who receive both the minimum diet diversity and minimum meal frequency. And you can do this computation with non-breastfed children as well. For the purpose of this analysis, we're also looking at consumption of specific foods and food groups. And as Lana pointed out, there are instances where there is an increasing rise of sugar-sweetened beverages in the diet, but there's also a decrease of nutrient-dense foods such as animal source foods. Again, as I mentioned, the data that we utilized is existing data. There's a phenomenal data source in Jordan, which is the Jordan Population and Family Health Survey. We were able to download 6 surveys from 1990 to 2017. In addition to the data on the child, we also collected information from the survey on the mother's education, on wealth index, and we merged all this data into a single database, which was a little bit of a piece of work because we had to standardize all the variables. So everything that I'm presenting to you all over time has been standardized, all the variables. We conducted descriptive statistical analysis, but we also did inferential work, which included looking at conducting multivariate logistic regressions. So this is just to highlight to you the number of children that we had per survey year. And so hopefully this works. Yeah, so we had about 11,000 children across all the survey years that were between the ages of 6 and 23 months. I'm just going to jump into some of the results. And what you have here is the percentage of children who are 6 to 23 months of age across the survey years. And you can see it starts from 2002. We didn't necessarily have data. The data that allows us to compute this for the earlier years, but you see that there is a drop irrespective of what age group the child is in terms of having met the minimum meal frequency. So essentially, we have basically less than half of the children who, especially the age 18 to 23 months, okay, sorry, I got some little reminder here, that were being fed the minimum number of meals for the age. That's pretty drastic, right? That's a pretty large number. And just to remind everybody, this is a nationally representative data set that we're looking at. The second thing you look at here is the percentage of children who have met the minimum diet diversity. And what you see is there is a decline over time as well. And essentially only one in 2017, which is the last data set that we have, only 1 out of every 3 children met the minimum diet diversity. And it is the lowest in the youngest children. So if you look at the blue line at the bottom, that's the child which is 6 to 8 months of age. So they already were struggling in the 2000s in coming up to about 40%, and now that's even dropped down even further. So the question is, what is happening to these kids, right? Like, I mean, surely they are receiving something, but what they're not receiving is the right kind of diets. And we'll get to that in a second. But I just want to point out to the fact that the same thing happens with minimal acceptable diet. And of course, it is a combination of MMF and MDD. So you find that there is a decline, that only 1 in every 6 children actually receives a minimal acceptable diet. And again, this is the lowest in the age group that is 6 to 8 months of age. Now, it's not unusual because this is a time when the mother starts introducing, and or she may have already started introducing foods, but it is a time when the infants have a little bit of a hard time consuming family foods, and or, you know, there is that period of time, but it's the most crucial period, because if you don't get the right foods at this moment, and if you're just feeding them juices, you're creating bad habits at that early age, right? And then, of course, this is something we've talked about yesterday, but you see that the trends in consumption of breast milk substitutes have shot up. These are the data from we actually did have from 1990 onwards through 2017. And you see that there was a dip in 2017, but we think that was because there was some kind of crisis with infant formula, because in 2012, you see a huge spike in the consumption of milk in this population. So basically, it's higher in children who are younger, so under 12 months of age. So people are definitely introducing infant formula very early in life. Now, this is the part that I really want to highlight is 2 things. One is juice consumption that has sort of was low, then it spiked, and it's kind of tapered off, but it is pretty high, where you see at the end, it's about 60% of kids under the age of 24 months are consuming juice, and most of this is sugar-sweetened juice. And then the right side, what you see is the consumption of tea, which is also pretty high, particularly in the older children. Again, as we're all familiar, tea is going to be sugar-sweetened. So there's essentially in juice, currently 1 in every 2 children, and I think this echoes what Lana highlighted in her findings, that it is considered socially acceptable to provide sugar-sweetened beverages to children that young. But the unfortunate reality is, on the other end, the nutrient-dense foods have reduced. I'm sorry, I'm going kind of edge of my presentation, but I'll finish up. What you see is the vitamin A-rich fruits and vegetable consumption has dropped. And in fact, only 1 in every 6 children actually consumed dark green leafy vegetables or any consumption of fruits and vegetables. So that's that is, again, this is the age. Introducing fruits and vegetables is very critical, because again, that is the time when habits are formed. In terms of the animal source foods, there's been a little bit of a decline in egg consumption. It was the highest in 2006. And there is a little bit of a dip in the consumption of meat, fish, and poultry, but it's pretty fairly high. So at this stage, about 4 out of 5 children are consuming animal source foods, but in general, there is an overall decline in the consumption of eggs, meat, fish, and poultry over time. We conducted multivariate analyses, as I mentioned, and we controlled for survey years. And the first bullet you see here is looking at trends over time and essentially repeating what I've already said, that the children in 2017 were more likely to consume juice than in 1990. They're less likely to consume vitamin A-rich fruits and vegetables than from the data from 2002, and less likely to consume meat, fish, poultry, fish, than in 1997. And the reason why this year's change is because we didn't have data for the prior years. But effectively, as of 2017, more consumption of juice, less consumption of vitamin A-rich fruits and vegetables, and less consumption of animal source foods. Three messages that very much correlate with what Lana has highlighted in her presentation. In terms of looking at it as an overall pooled analysis, what we find is that children with educated mothers and wealthier households controlling for survey years were more likely to achieve all the nutrient-dense food groups and the indicators, but they were also the most likely to consume infant formula, milk, and juice. And wealth was negatively correlated with tea consumption. So what it tells us is that there is a little bit of nuance here that we have to observe. It doesn't mean that if you're wealthy, you have a better diet, and if you're economically constrained, you're going to have a poor diet. I think it's a combination. So essentially, in the end, I'd like to say that there is a decline in complementary feeding indicators as well as a nutrient-dense diet introduction to children under 24 months of age. The key point here is there's a significant increase in sugar-sweetened beverage consumption. That is really something that we need to highlight and address because, as I said yesterday in my opening, dietary habits are established early in life, and they do have a risk later in life for the child. So thank you so much, and I think I just made it in time.
Now? Okay, yeah. So thank you, Dr. Shibani, for shedding the light on concerning trends regarding breastfeeding and breast milk substitute use and children's diet quality in Jordan, and also for mentioning shared factors with the previous talks. So thank you so much. Now we are going to move to our next presenters. So we will ask you to move to this table so that we can take questions later. Thank you so much. So for the second part of this session, we are going to have Dr. Shereen Hamadneh from Al-Bayt University, Deena Al-Zoubi from University of Jordan, Dr. Al-Maseimi from Al-Balqa Applied University, and Asma Al-Khateeb from Plan International. Timer هنا, okay? Yeah, have a seat. Okay, so for our next presenter, Dr. Shereen Hamadneh, she is an associate professor from Al-Bayt University. So welcome.
Good morning. Yes, okay. I just see. Okay. Today we're gonna presenting about parental feeding practices for newborns, infants, and young children in Jordan, the potential for improvement. I was applying for a fellowship proposal for this topic. Complementary feeding is the process that begins when breast milk formula alone is no longer sufficient to meet the nutrition requirements for children. Therefore, foods and fluids required for children. The introduction of complementary feeding covers the period from 6 months to 24 months, 2 years old. Indication for complementary feeding include when to start, the frequency, and minimum acceptable diet. Significances. World Health Organization estimates that out of 5 children are stunted in low-income countries. Social and cultural aspects in societies play a major role in parents' practices of introducing complementary foods to children, especially in a culturally rich region like Middle Eastern country and Jordan. Problem statement. I'm the founder and director of Infant Safe Care in Jordan. During my field research in the past 10 years, I found many sudden infant death syndrome that related to risky behavior in the caregiver to a young child, including feeding practices. Many recent deaths of infants and young children have occurred as a result of wrong steps by parents in feeding their children, leading to choking. Do not forget that there is a large percent of mothers now lifting the breastfeeding, so the rate of breastfeed become low. Furthermore, many wrong choices are associated with health disorders or risks. Research question. The important axis here is what is the misinformation parents have about feeding the child? What common issues? Also, are parents sufficiently aware of proper feeding methods? What are the sources you often use? Now, some of them, especially the young mothers, they tend to use social media. In the past, they get the information from grandmothers and relatives. So what's the main source for information? We need to know. What is the role of healthcare providers? Healthcare providers here, I don't choose a one only area. May see that among nurses, midwives, also physicians. So also we need to know what the role of researchers, politicians, and decision makers in Jordan and international community. This is in order to have a change. If we need to make a change, this needs a teamwork from all aspects. Methods. A jury literature will be accessed and structural literature review from 2010 to 2022. As I mentioned, this stage is completed. The second stage also is running. Mothers with infants aged 12 months or younger will be recruited to participate in this study. A semi-structural questionnaire will be used to collect information about socio-demographic characteristics, information about common infant feeding practices. Also, this will be distributed either online or on paper. Phase 2 to run will target north of Jordan, the area where the mother go to the healthcare centers and access them to get more information by interview. Then we will build a program. This program to depend on the baseline information that we can find from the survey and interviews, focus groups. Then we'll build a program and adapt an action research approach. Why an action research? Because it's a new program. We need to make evaluation in a different stages for this program. In studies in US, the introduction of solid food before the age of 4 months was reported more often in infants who were not have a breastfeeding. Also, younger women, single or less educated mothers. Similar research of Arab region has found that parents introduce solid foods at an early age to infant due to some factors that including social, demographic, economic, cultural, and religion, faiths, living conditions, and environment. How is that? When I went to refugee camps, sometimes they told me they provide feed for their infants while they are less than 4 months of age because they need to feel full. So providing other type of food than breastfeeding will make them feeling full. Also, the mother facing some difficulty in providing breastfeeding because of her emotional or psychosocial situation. So the most common reason mothers cited for early introduction of solid food were linked to their beliefs that their infant was old enough to start eating solid food. And sometimes the infant seems hungry, and mothers also indicated that if they provide complementary food for the baby, he will sleep enough. Mothers often have advice from infant care provider, healthcare providers, and they advise them to provide a complementary feeding, and sometimes before age of 6 months. This research is highly needed for Jordan area. It will explore complementary feeding practices for under 2 years children and the difference of other research. In this research, I targeted parents, father and mother, not only the mother. Also, if we see the Jordanian culture, we get information from grandmothers in sometimes. So having the interview, this make this study more rich and in depth. I can gain more information from interview. The study will investigate factors associated with complementary feeding. Finally, this study will conclude with recommendations for future research, provide basic essential information, and support building an intervention program that targets and appropriate for the Jordan's culture. The report of this study findings will be presented to the Ministry of Health and World Health Organization. Researchers, policymakers, and health professionals can support change and manage intervention programs. I think we went to the, yes, this is the last slide. This photos from my program, Infant Safe Care Program. We run this program in Jordan. And when I met with the Jordanian women and many issues in relation to feeding, especially complementary feeding. Last 2 months, a child passed away because a wrong choice for choose the food for this child. The child was 6 months of age. The mother gave the baby a wrong choice of feeding that lead to choking. Okay, thank you for listening.
Thank you, Dr. Shereen, for your research approach that will open a door to what we are going to do regarding the feeding practices for infants, especially in high-risk groups in Jordan. And hopefully, with this symposium, the message will be delivered to all policymakers. So we are going to welcome our next presenter, who is Deena Al-Zoubi, an advocacy and business development manager from University of Jordan.
Good morning, everyone. So my name is Deena Al-Zoubi, as my colleague just mentioned. I am the Advocacy and Business Development Manager at the Royal Health Awareness Society, but I actually did this research as part of my work in the University of Jordan. I was a student. I was mastering in public health. And this research was supervised by Dr. Raida Al-Qutb and Dr. Iman Badran, whom I think you're all familiar with. This kind of touches a little bit on what my colleague was discussing a little bit ago in terms of the high-risk groups within the infant population. And in this research, what we wanted to do was focus on preterm infants, and in particular, late preterm infants. So I think it's good to start a definition of what this population really is. Sorry, I forgot that I have to click. Great. Late preterm infants are those who are born between 34 and 36 weeks of gestation and 6 days. They are indeed the fastest growing population within preterm births. 12.5 million infants are born yearly within the late preterm population, and they constitute around 84% of preterm births. We have a few studies in Jordan that try to quantify the prevalence of late preterm births in Jordan, and they found that it is between 70 and 85% of preterm births. So if we were to try and translate that into numbers, if 14.4 out of 100 children are born preterm in Jordan, around 10 to 12 of these are late preterm. So they're a pretty huge portion of the preterm population. So why did we want to study late preterm breastfeeding? So we know that they have an increased general vulnerability in terms of health outcomes within the preterm population, and they have feeding vulnerabilities as well, and we're going to discuss a little bit of that later on. And there are special benefits to breastfeeding this population within infants. Usually, late preterm infants' health outcomes are compromised. So as most of you know, late preterm infants sort of look and weigh kind of like term infants. So they are perceived by healthcare staff as being, as close to normal as you would think. Unfortunately, this, along with the terminology that is used to describe them, so before they were called the late preterm infants, they used to be called near-term or close-to-term infants. And they changed that terminology because, along with the perception of their normal weight and that they look normal, it unfortunately predisposed them to adverse health outcomes. So in Jordan, neonatal death is actually the third most common cause, and 52% of these neonatal deaths are attributed to being born prematurely. And late preterm infants are actually 2 to 3 times at higher risk for morbidities, including hypoglycemia, jaundice, sepsis, and others. So I was talking to you a little bit earlier about breastfeeding difficulties in late preterm infants. So they have a lot of factors that are unfortunately working against them in terms of breastfeeding success. So they have a physiologic and neurological immaturity that makes it hard for them to coordinate the action of, sucking, swallowing, and then taking a breath. It seems like something that is natural and easy, but when these children, because of the neurological immaturity that these infants have, it makes it harder to do this action of coordination, which predisposes them to difficulty in terms of breastfeeding. They have an energy negative balance, which means that the energy they need is a lot more than the energy they store and have, which makes them sleep a lot more than their term counterparts, and it makes it harder for the mother to feed the child when they're sleeping all the time. And then we also have the milk production negative feedback loop, because when the child is not emptying the breast when they're breastfeeding, we all know that this ends up affecting the production of breast milk, which makes it even harder for the mother to breastfeed. And, as mothers and healthcare providers, we all know that being born with a child who is, born disadvantaged because of their preterm status, it makes it more likely for the mother to be anxious and stressed. And we also know that affects the breastfeeding outcome as well. There's also a delay in milk production, because most of these children, we also know that they're not born normally, they're born through C-section, and we all know what comes with that and how it delays milk production. But there's also this controversy among healthcare providers in terms of, should we really breastfeed this part of the preterm population, because they've noticed that the late preterm population, they were more likely to be readmitted to the hospital after being discharged because of feeding related difficulties, so hypoglycemia, dehydration, and whatnot. And this was more prevalent in the children who were breastfed, right? So this made it sort of an issue of, should we breastfeed these infants, or should we just give them formula milk and avoid all of the complications and morbidities that come with lactation? So breastfeeding, in late preterm infants had its own set that kind of overlaps with the overall difficulties that are faced by mothers in general. So they suffer from delayed initiation of breastfeeding, and sometimes this is due to medical reasons, because the mother sometimes has to be separated from the child, and the child has to receive special care that ends up making it hard for the mom and the child to be together. They have increased challenges encountered. I talked a little bit about earlier, and this ends up causing early cessation, and we end up giving them a decreased duration of breastfeeding in general. And as I said a little bit earlier as well, they have, they benefit just like every other child from breastfeeding. And the benefit that I would like to highlight among the ones that you can see on the screen today is the cognitive, neurological, and visual development, because this subset of preterm infants was found to have was found to greatly benefit from breastfeeding, and the scores, the Bailey Developmental Score, was found to be higher among children in that subset who were breastfed compared to those who were not breastfed. So it's really important that we focus on them. We know that this subset of preterm infants are born with a decreased ability to handle oxidative stress. So this also causes the antioxidant capacity within the breast milk is protective of them, including other benefits that I will not mention because I don't have a lot of time left. Okay, so in this research, we wanted to learn a little bit more about the knowledge, attitudes, and practices of mothers about breastfeeding. So we wanted to know if they had sufficient knowledge, if their attitude was positive towards breastfeeding these children, and if these practices required improvement. I'm going to skip all of that and jump to the results because I don't have a lot of time. So it was a cross-sectional study. We took a sample of around 150 children in Al-Bashir Hospital. This was right before COVID started. And this sample was selected. It was a convenient sample. So as you can see, the sample, the mothers within the sample, almost 3/4 of the sample had a tawjihi education or less, and most of them were unemployed. The mean income of the sample was around 400 JDs. Most of the mothers ranked within the fair knowledge group, so they did not have the amount of knowledge that was needed for them to, continue with breastfeeding successfully. We found out that mothers without health barriers, and we were talking about medical reasons for breastfeeding, were more likely to have better knowledge and were more likely to have a better attitude towards breastfeeding. We found a positive relationship between the subject's age or the mother's age, the number of family members, which I think a few of my colleagues mentioned earlier on, and of course the family income. Mothers had a good attitude in general towards breastfeeding their late preterm infants, and we also found a similar correlation as with knowledge with mothers who didn't have any health barriers that hindered breastfeeding, and we also found a positive relationship with mothers who were employed. We also found a positive relationship also with the practice that was in the end adopted by the mother. Finally, we also found a higher practice score in mothers who didn't have any medical issues with breastfeeding, and the mothers who didn't have any issue initiating early or initiating within the first hour of birth. So I think we discussed, a little bit about the vulnerability of the late preterm infants. And to conclude this, we know that mothers of this population in particular are in need of focused interventions that tackle their specific challenges and their unique set of barriers that often prevent them from breastfeeding and giving their children exactly what they need to set them up for a healthy future. Thank you very much.
Okay, so thank you, Deena Al-Zoubi, on focusing on the difficulties associated with breastfeeding of the preterm, which is already associated with a lot of comorbidities, and the knowledge, attitude, practices of the mothers, which also needs improvement. So for our last speakers, we are going to have Dr. Al-Maseimi, which is an assistant professor from Al-Balqa Applied University, and Asma Al-Khateeb, a senior project manager at Plan International.
Bismillah ar-Rahman ar-Rahim. At first, I would like to thank you all and welcome you all. The topic today may be a little bit strange, a new topic. For me, it's interesting, but I don't know, and for all the female, I think it's interesting topic. For the male, I don't know if they like the idea or not. This topic, or the title of the paper, which is Situation Analysis, Male Engagement in Early Childhood Development in Jordan. The ECD, the Early Childhood Development, is a term refers to the physical, psychological, emotional, and social and social development that occur at a stage for the child, age from birth till under 9 years old. Why male engagement? Really, the topic of male engagement in child rearing and raising had a lot and great attention in the recent years. This because of its direct benefit, either immediate or long-term benefit on the well-being and on the mental health of the child, either on the cognitive, as we say before, the social development, and the higher educational achievement outcome. This ultimately results in them having better relationship with their peers, also increased the self-esteem and the life satisfaction. Also, when we say male engagement, many previous studies say that it's tackle the discriminatory gender role problem. It was found that men engagement matter because mothers who feel support from his fathers of children, she feel less stress, less parenting stress than other that don't have support from the father. Also, sometimes in literature review, we found that The improved relationship between father and the child facilitate the adoption of some recommended practice, either nutritional practice, health practice, and other practices that may affect the child outcome. In general, the child outcomes may be affected by many factors, as we say before. The main objective of this study, if we want to say what is the main objective of this study, is to actively support parents and caregivers to be more responsive and empowering to raise the children in a safe and enriching environment, where ECD services are integrated across different service providers and made it at a national priority. Other objectives, it's very important to determine the limits and the barriers that stand against the participating of the men to their child, and develop various approaches to help them better engage with their children. It's very important also to ensure the existence of programs that work with both men and women as equal partners. Also, it's very important to evaluate and assess the current situation and the real situation of male engagement in Jordan, in order also to establish participatory education based on equality between boys and girls. Children always need to grow up without the effect of social norms and gender norms, because it's limit their potentials usually. Also, the objective, one of the objectives of this study is to lobby for laws and policies to ensure fathers' participation in the upbringing of their children. In order to measure the reality of the male engagement in Jordan, this will be examined by mainly measuring 4 strategic thematic areas. Number 1, power and privilege. Number 2, early childhood development. Number 3, parenting programs. Number 4, policies. With respect to the ecological framework, where there is interactive or interplay rule between interpersonal, personal factors, social and institutional factors, and public policy. In order to achieve our objective, the data will be collected using a mixed method approach, either for qualitative and quantitative terms. 4 main tools were used in order to measure the data and to collect the data. The secondary data extracted from the previous literature review, while the primary data, in order to collect it, a survey questionnaire, a sample of 1,213 caregivers who have children up to 9 years from all over Jordan, now north, south, and centers will be taken. A total of 6 focus group discussions were conducted in Jordan with the health center staff, community members, and CBO's leaders. Around 22 key informant interviews were conducted to collect qualitative ideas and point of view through an open dynamic discussion with key government stakeholders, NGOs, local community-based health committee, and community member and head of CBOs. This study showed several results regarding the 4 strategic thematic areas. Let's start talking about the first topic, or the first aspect, which is power and privilege. Regarding power and privileges, over the world, especially in Arabic countries, there is still a strong gender and social norms between men and women. Men all the time has a strong privileges and power than women. The shape of the relationship between men and women will be determined and affected by many social and cultural factors from the family, from many cultural factors. As a result of this, some of the results. Some of the results, Okay. Men usually have a role of breadwinner, decision maker, have the financial power. Women have a role of caretaker, also have a responsibility of take care of child health. One of the most important findings that we see that the low rate of assistance for the household chores from men to women. This is the point of view of women. The men justified that by the long time or the long working hours they spend outside the house. Also, they don't know how to do this job, and it's the responsibility of women. Also, 66% of respondents say that taking the child to health center is the responsibility of women. Now, Dr. Asma, my colleague, will continue presenting the other presentation and other results, the remaining results of the 4 aspects. Thank you.
I think راح شكل البرزنتيشن.
Hi everyone, and thank you very much. Thank you, Dr. Ula. We thought that it's a very important study to show how it's important having male engagement in all the child life, in the health and in the education part, in the protection. So we need to, just 1 minute. لا بالعكس صح؟ تمام. It's very important to have male engagement in different aspects, in the health, in the education, in the protection, in all general aspects. So what we try to do just to understand what is the situation of their participation. As Dr. Ula said, the power and the privilege, it was one of the biggest aspects that we have different findings and different, the main reason of not participation on their children's life, because the social norms and what is the culture in general. The second thematic area that we need to discuss now, the early childhood development, which mainly is speaking about the practices that the fathers and the male caregivers done with their children. So the first finding, it's 62% from the parents expressed that the male caregivers cannot take their own responsibilities on raising their children. They need all time the support, while the women, no, they can't take the full responsibilities of the children. The second one is the fathers engage in different areas in their children's lives, but the first one of this area, it's the recreational activities and the personal matter. So we did not find a lot of engagement on, for example, the education, the health, as Dr. Ula said. Okay. The third aspect is the parenting program. We know that the parenting program, it's very important just to have more information about how we can raise our children in general. So is the fathers or the male caregivers attending the parenting program? The first finding, we find that most of the parents, they did not attend the parenting program, and also the participation on the parenting program, it does not depend on the topic of the sessions. The second one, it's also parents accept to refer them to particular service providers to give advice and guidance, coaches how to raise their children in general. And the last one, it's the workplace for parents, because we need supportive workplace for male caregivers to be engaged with their children in general, in their children's life. They need to engage in health, in education, in protection, and recreational activities. So they need a flexible workplace. So the workplace was not flexible as the study. The fourth aspect, it's the policies. We showed here, the participants showed that we don't have a very supportive policies to have more male engagement in general, and when we ask them about the main responsibilities for whom should be to have male engagement, they all agreed that it should be for the families. It's not for the policies or institutions or the laws. And here's the findings, as Dr. Ola mentions. So let's go now to the recommendation. So the first one, the recommendation coming from all the tools that we use, the focus group discussion, the interviews, that we need to change the name of mother and child centers, because the name of it's not engaging the fathers or the male caregivers to come to the health centers to be part of their health, of their children's health. So the first recommendation was to change the name to, for example, child care or family department, anything, but we need to make sure that it shows that we need to engage the male in general. The second one is to develop a national strategy dedicated to enhance male engagement in raising their children through early childhood program and service providers. And we need to have a lot of collaboration and intensive work to have collaboration between community and civil society to provide support for male engagement to raise their children through, for example, guidelines, through publication, through coaching, through awareness session, etc. And to establish coordination between relevant actors, just to make sure that at the end we have to ensure active participation of male in children's life. One of the recommendations was about the media, which is has a very important things on the male engagement in general. So we need to activating the role of media to have more male engagement in parenting session, to attend the parenting session, and to need to more information why it's very important, the objective of it, the content, the last impact on the children and also on the mother and also in his as a father. And we need, this study shows that recommend to enact policies to enhance male engagement, such as the laws. For example, the paternity leave, it was 1 day, and in 2020, we have the paternity leave for 3 days. So we need the laws to support male engagement, how they can support if we don't have or give them the space to support their children in general. So we need to have more days, also the sick leaves, how they can. Also, one of the things that coming through the discussion and the interviews that we need in the workplace of the fathers, we need to have daycare. It's not just the responsibilities of mother. It can be for the mother and father, so they can interact with their children in the nutrition, in the health, in the education, etc. The last recommendation, there is a lot of recommendation, but this is the main recommendation, to approach the Ministry of Education and the Ministry of Higher Education. It was before, before the changes, to have like a course or curriculum for all the students on the family affairs and child care from the beginning, because we need to enhance them from the beginning just to make them able to be effective part in the future and in the community. And here is the main resources. Before I'm finished, I want to tell you that this study, it's leading by Plan International, but it's not just a plan. We have a very supportive and collaborative institution that support in this study. The first of them, it's the Ministry of Health, RHAS, NCFA, War Child, IRC, HI, QRTA, Hashemite University, and Dr. Asil Shawarib, also other colleague, Dr. Ola Al-Maseimi. Thank you for all of them, and we have to have all of these just to have more information about how we can have a lot of strategies, recommendation to have male engagement. Thank you very much.
Thank you so much, Dr. Ola and Asma Al-Khateeb, for a very interesting topic that touches every house, at least in Jordan. So a message from here, we need everyone involvement in the upbringing of children. So I guess we have some time, or like 5 minutes for questions. I can't see yeah. So maybe 1 or 2 questions. Can you, the mic please?
Good morning. Thank you very much. It was very informative, actually, and very nice panel. I have actually 3 questions for 3 different speakers, but I will try to make it direct.
Is it for a
Dr.
specific
Ines
speaker?
Assaf from
Is it for a specific speaker? I didn't hear you.
Yeah. I will give a specific speaker.
Okay.
Yes. I have Dr. Ines Assaf from Applied Science Private University. First, I will go to Deena Al-Zoubi. Thank you very much, actually, for your very informative and very important area of study. I found it very new and actually new for us, actually, to give this information. And it opened also a lot of intervention studies. It opened a lot of things to do in the future. I just want to ask you about the attitude. You mentioned that the average was 15.9. What does that mean? Is it really positive or negative? The other question, you mentioned that was a cross-sectional study, but I found it retrospective study. Can you really explain more about it? Because I didn't know how you collect the data if it's actually retrospective. I mean cross-sectional. Can I just continue with asking all the questions?
Can we have just one? If there's no other question, we can come back to you. Thank you.
Yeah, okay, thank you.
And I'm going to ask you to...
Okay, so she asked about the attitudes, about the number, whether, like, to explain it, and the design of the study.
So, is it working now?
Yeah.
Yeah, okay. So in terms of the attitude, I didn't mention, because I didn't have the time, that we didn't have a ready-made tool to use, right? So we made a tool that was based on the relevant guidelines that related to late preterm infants, but these were also focused on practices more than anything else and more than attitude. And we tried to compare with similar regional and international studies that measured attitude in general, and tried to kind of have a comparability between how we measured attitude in this study and how attitude was measured there. So the attitude score was in fact positive, right? So in general, the score, it was presented as an absolute number, but it was positive. And I can talk to you a little bit more about that, and I can share more information, and I'm happy to share the tool as well if you'd like to look at it. And I also, I'm sorry, but I didn't hear the second part of that question.
It is the design of the study.
Yeah.
You mentioned that it was a cross-section.
Yeah, it was a cross-sectional study. So we used a survey, and we surveyed around 150 mothers. It was not a retrospective. Yeah.
Thank you. So more questions? Anyone? Yes?
Thank you. I'm Doris Youngs. I'm with the Community Health and Nutrition Project, and mine is more of sort of a call for research, I guess. Dr. Shibani talked about this importance of the complementary feeding, not waiting too early, or not waiting or going too late, like basically hitting it, the timely and appropriate. And I have to tell you, I was extremely, it really sort of, wow, when you said that some of the children were not getting between 6 to 8 months the appropriate number of feedings. And yet, when we look at the data, a lot of the data sort of shows that things are fine. Children are going, you know, we don't have a lot of malnutrition, which I would have thought when you look at those two. And so it's just an area with all these, you know, researchers in the room, and maybe it's an area that we really need to focus more on, and sort of see why why do we have this sort of conflict in the numbers of the data, and how is it, you know, we are assuming that they're getting their meals, they're getting something, whether it's nutritious or not, but it's sort of an area that I think we need to focus more on. So thank you for highlighting it. And I would love to hear your comment.
Okay. So
yeah.
If I just take this. So yeah, I think that's a very good point. And so it's not about food security. It's about, I think, two things. One is, I think the indicators are not measuring what the kids are eating. They are measuring, they are meant to measure feeding practices within the context of food insecurity to some extent. So therefore, it may not be capturing things like sugar-sweetened beverages. They don't get counted as meals, for instance. So if the kids are receiving milk and formula and juice and soda, that may not get counted in that indicator. So there's a little bit of an issue with using the indicator within the context of Jordan, but it is one way of looking at it. So, and then the other thing is that, and this is something that I know no one here from USA Jordan is here, but they did identify this as an issue, that if the minimum diet diversity is so low, but there isn't food insecurity, so what is going on? Again, the issue is excessive consumption of foods that are not accounted for by that indicator. So those indicators are created from a list of 10 or 15 questions which don't account for, did you give your child sugar-sweetened beverage? Did you give them sugary foods? Did you give them fried foods? None of that gets counted. And I think what happens is that the kids are being fed, but they are not being fed the foods that are in those tools. And so in fact, my understanding from USA Jordan is that this particular upcoming survey, they have expanded the tool so that in addition to these indicators, we should be able to compute things like diet quality score and scores that will allow us to account for consumption of ultra-processed foods. I think that is the big problem, and you're right, I'm just speculating based on the data that I have, but I think we do need more research on that space.
Yeah.
And I'd also like to say one more thing. Sorry, I know, I'd like to say that if anybody's interested in this area, please look into the food environment in Jordan, because this is not about a food insecurity issue, it is about the kind of foods that are available and the convenience foods that are available in the marketplace. And I would say that that would be one hot topic to look at if any of you are interested in this space.
Yeah. Thank you, Dr. Shibani. So we will conclude, due to the time limit, we will conclude this session, but the questions can be answered during the break. Our speakers are going to be available for you. So we thank our speakers and we thank you for the listening. Thank you so much.
Thank you very much, Dr. Hana. Thank you for all the speakers. We know that was a very interesting session. Indeed, do not hesitate to discuss it further over the coffee break. So we will have our coffee break. We will be back at 10:45 sharp, please. And don't forget to pass by the posters room just to check the poster and the research is there. Thank you very much. See you again.